patient care and how the data can be used to plan and improve health service delivery. It's really important to remember that if you don't measure something, you can't improve it. But as a starting point, you can't measure anything without good data. And it is really important that you collect the right data for what you want to measure. Don't measure something just because it's available. Collect the data that answers the question that you want to measure. While my training as a doctor many years ago, or since my training, I have worked in clinical research, observational research, epidemiology, as Reinhardt said, rather than experimental or clinical trials research. My area of special interest at the moment is cystic fibrosis liver disease. Less than 10% of people with cystic fibrosis, which is a rare disease, will get liver disease. So therefore, I work in a very niche area. Cystic fibrosis, as you all know, I'm sure have heard of, is a genetically inherited disease, and both parents must carry the CF gene for the child to become a CF patient. In Ireland, for some reason, the medical profession love to tell us that we have the highest incidence of cystic fibrosis in the world. And asking them how many patients they think there are in Ireland with cystic fibrosis is always very interesting. They usually consider that in Ireland you would probably have 10 to 15,000 patients with cystic fibrosis. The Cystic Fibrosis Registry tells us that in 2020, our last annual report, there were just short of 1,500 patients, 1,500, rather than 10 to 50,000 that people think there is. It's a very small number of patients with cystic fibrosis in Ireland. That doesn't take away from the awesomeness of the disease. The Cystic Fibrosis Registry was established in 1999 in order to improve the care and outcome for patients with cystic fibrosis. Cystic fibrosis was first described in the early 1950s. And when it was described first, children didn't live past their second or third birthday. Now people with cystic fibrosis can expect to live into their fifth decade. And I just wonder if we had a look at what has changed since the Cystic Fibrosis produced its first annual report in 2002. Cystic fibrosis collects specific data around CF, and a way of disseminating its data is through an annual report, and this is the case for most registries. Participation in the registry is by consent, and we would have over 90% of patients with CF in the country would be members of the Cystic Fibrosis Registry. This is going to be somewhat less. It was somewhat less last year and will be somewhat less this year due to the pandemic and issues with recruitment and enrollment of patients. But because we have close to 90% of patients enrolled in Cystic Fibrosis Registry, it is reasonable to extrapolate the data that we collect and the outcomes we report to the whole population of cystic fibrosis. So therefore, it's a valuable data set for patients with cystic fibrosis in terms of planning their care. So what has changed in the registry since the reports of 2000, the early reports of 2002? And can we use this data to compare our performance of the care of patients with cystic fibrosis in Ireland to other countries like the UK, Europe, North America? And we certainly can. We contribute to the Cystic Fibrosis Registry, European Cystic Fibrosis Registry, and we consider ourselves one of the best in class in terms of contributing data, having good database set up. And so it's a valuable resource. But what has changed? In 2002, the registry reported that there were 1,100 patients with cystic fibrosis in Ireland, while in 2020, there were just short of 1,500 patients with cystic fibrosis in Ireland. So the number of patients with cystic fibrosis has increased. This might be a surprise, considering it's a genetically inherited disease of such severe consequences. But the reason for this is because care for cystic fibrosis is dramatically improved. One of the most important findings when we look at the differences between 2002 and 2020 is the proportion of patients under 18. In 2002, there were close to 40%, or close to 60% of patients on the CF registry were under 18 years of age. Now, this isn't because they didn't include patients who were older. They had good coverage then as well. while in 2020, the proportion of patients under 18 years of age on the registry or participating in the registry was less than 40%. So a huge decline in the number of children with CF on the registry. And this is because as survival had improved, the proportion of adult patients had increased. But there's another important piece of data that the registry has produced that we must take into consideration if we are going to use registry data to plan services that are needed. The increase in the adult population of patients with CF would suggest we should invest hugely in adult hospital services and reduce the investment in pediatric services because the numbers have changed. However, what we also report is that between 2008 and 2014, approximately 40 children every year were born with cystic fibrosis in Ireland. When we look since 2011, since the newborn screening was introduced, this has reduced dramatically to somewhere around 27, 28 patients per year. So this is a really important piece of data for policymakers and planners, because not only has the population, the older population increased, there's a huge decline in the actual numbers of children with cystic fibrosis in Ireland, and this will continue. And in the years to come, there will be much fewer children progressing to adulthood because they haven't been born with cystic fibrosis. So therefore, we need to balance the decline in the incidence of cystic fibrosis in the pediatric population with the longevity survival that we see in older patients. And this is really important for planning services and how we deliver them, okay? And one of the benefits as well of newborn screening is that we rarely now see families with 3 or 4 children with cystic fibrosis. Because once you are diagnosed, once your first child is diagnosed with cystic fibrosis, it is highly unlikely that you will have another child with cystic fibrosis, and that's really important. Whereas previously you could find that it was a second or third child who was diagnosed in the family that was diagnosed with cystic fibrosis, and the older children who mightn't have been diagnosed for various reasons also had cystic fibrosis. So you find big families, or large number of children in certain families infected with cystic fibrosis. Okay. One of the important things that we in the registry are very proud of was at the start of the pandemic, we and other registries were the go-to source for the Department of Health to identify how many people were there with cystic fibrosis in Ireland. They probably had a rough idea, but where were they? And how were they going to protect these people with significant lung disease from the pandemic? So Cystic Fibrosis Registry is an independent data source. It's independent from the Department of Health, independent of the HSE, though has funding from the HSE, independent from clinical care, from hospitals, from consultants. So it is seen as a registry, as are other registries, that produces valid, independent data that can be trusted. And this is really important. Okay. Another big registry in Ireland, like the Cystic Fibrosis Registry wasn't the first registry in Ireland, and registries have been around internationally for years. Like the North American Cystic Fibrosis Registry was formed in 1955 or 1966. Foundation was established in 1955. They established the registry in 1966 and have done huge work since then, and huge work around the newer treatments. But one of the really interesting things is that the North American Registry is the national registry, like the Irish Registry. Okay, we report on all children in the 26 counties of Ireland, whereas the North American one, it's really because of the structure of the American healthcare system that it is in the National Registry. Another registry that is really important in Ireland and has delivered hugely for the population of Ireland is the Irish Cancer Registry, which was established in 1991. And the aims of the registry were to collect and classify information on all cancers that occur in Ireland. And it's interesting to read the aims and objectives of the National Cancer Registry on their website. And it is to identify, collect, classify, record, store, and analyze information. It's a data management system around all cancers, around patients with cancer. And it is to control the use of this data for research in approved research projects. So it's not that everybody can take the data from the Cancer Registry or the Cystic Fibrosis Registry to do research. It should fit the purpose for which the registry collected the data for which they have consent from participants, and that it is important that the registry ensures that the question that is to be addressed by the researcher can be addressed by the data that the registry holds and is not misinterpreted as data. Okay, the National Cancer Registry is a statutory body established by legislation and funded fully by the Department of Health. So very different to most patient registries that are in Ireland. And currently, sadly, in Ireland, there's no strategy for registries. There's no one-stop shop in the HSE for where you might establish or how you might establish registries. But I think post-COVID, I think the HSE will look very different on registries. But you might say, well, why can't the HSE just do all this themselves? And sadly, there's a couple of factors. There's no national database. Even the National Cancer Registry must go through the pathology reports and the hospital records to get their data. So they can't even they don't even have a one-stop shop as a statutory body. So that doesn't exist. There is no health insurance, there's no national health identifier. So we don't have a unique identifier. In 1,500 patients with CF, back in 2012, we had 3 children under the age of 18 with the same name from 3 different counties. It was a really interesting issue. We would have been very careful about the Murphys and the O'Connors. These 3 children didn't have a Murphy or O'Connor name. And we had 2 of them in the one box for a long time. You know what I mean? We thought 2 of them were the one patient for a long time. So it is really important. A national health identifier must be put in place soon. We need electronic health records, but I think they will come hopefully soon. But I think what we lack in Ireland is a champion of data and how important data is. And the recent cyber attack, I think either will set us back years or could go the opposite way and could propel us into having really good integrated databases, because I do know there are hospitals in the country that are in real trouble, small hospitals in the country that are in real trouble still 18 months later with their IT systems. Registries are really important for rare diseases where they're small numbers. And this is, acquired brain injury fits into this category. And I think as medical professions, I think we struggle with conditions like ABI because or other neurological conditions. And I think it was, it wasn't too dissimilar to stroke years ago. We don't know what to do. We can't do anything. We can't offer a magic cure. So therefore we just want to, turn away and do nothing. It shows our incompetence and our lack of skill and our lack of expertise. And I think we just don't like that. We don't like not to be able to have the perfect answers and the right solutions. I think the introductory lecture by Professor Finns on Monday was absolutely exceptional. And I think, his, the hope and the possibility that he gave, I think is amazing. And I think we should all be very grateful for his contribution. But I think there are other things that were really concerned towards the end of his talk for somebody like me. It's only recently that acquired brain injury has got an ICD code. ICD is the International Classification of Diseases, and every disease has a code. So it allows international comparisons. It allows payment for conditions. It allows us to manage or to monitor hospital admissions and hospital care. There's no guidelines for the treatment of H. pylori. Ryan Hodge suggested there might be ones in the UK, but he suggested there were no guidelines. And there is no classification of disease. And before you can understand the disease, your basic starting point is to divide and classify. You must classify and understand. It's observational work. Differences between different groups with the disease. So I think there's a long way to go, but I think there is a possibility of changing the record, and whether that's here or whether that's internationally. I think we have a role to play in providing some kind of a registry, patient registry. And I think there's lots of, terminology around registries, whether they're disease registries, patient registries, or treatment registries, or research registries. I don't think it really matters. I think the principles are the same. The whole idea is that you collect a well-defined set of information to answer a specific question, which will address issues for either service providers, for patients, for doctors, or clinicians, depending on what your question is. So I would suggest, that ABI needs a registry of some sort. It is an enormous undertaking, but I think we should look carefully at where would you start and what's the current landscape. So are there international registries elsewhere? Do other countries have registries? And are there registries for allied conditions? I don't know, like my information and knowledge on this condition is very little, so I don't know the answer. But I think it's really important to know what's there before you start to reinvent the wheel. The other issue is that most registries start out as lists now on computers, forming on pieces of paper, that consultants with a particular interest in a condition kept, so they knew who their patients were, when they were seen, what treatments they were on. They're often, while you don't call it a registry, patient organizations have lists of patients for administrative purposes in terms of, their age, their address, and, depending on the organization, how much data they hold. These are starting points, not to be, considered that they're not going to be wrong. They're really useful places, especially for rare disease, where finding all the patients with the condition will not be easy. Okay, so what's out there is important to know, and it's by talking to other people, other organizations, allied patient organizations, what do they have, what do they do, or where could you move on from there? So what questions would you address? I think the first one is, and most important, is the magnitude of the problem, and I think we're aware of it. But I really like the logo on your screen here, leave no one behind. But unless you count, you don't know who you leave behind. If Granny takes the grandchildren to the park, she has to know how many she brought. She has to count at the end. She has to know if she's missing a boy or a girl and what age they might be. How is anybody going to help her look for Johnny or Catherine if they don't know, if she can't say, well, it's a 5-year-old with a green jersey. You have to know, you have to be able to count. Counting is a really important activity, and people don't think it's important, but it's, it's the basic premise of any research, and counting accurately and counting people in the same groups. You don't put boys and girls into the same, you put boys separately, girls separately, you separate people in classes. First class, second class, third class. These are all important separations and divisions. And, in pediatrics, one of the most interesting things around research is it is really important to understand the age of the child in terms of what disease they've got. I was very involved for a long time in H. pylori research, which is bacteria that causes stomach ulcers. And what was really interesting about this, it started off as a disease of adults because they got the ulcers, and the adults were very into it and into their treatment. And eventually it was shown that no, it was a disease of pediatrics. Children got H. pylori. You acquired it as a child. And what we showed in Ireland in a very interesting epidemiological study involving general practitioners is that if you were going to get H. pylori, you got it before the age of 5. And if you didn't get it by the age of 5, you weren't going to get it. So if you're going to prevent H. pylori infection, and it's really important because H. pylori, peptic ulcer disease has disappeared largely, but H. pylori is also a cause of gastric cancer. And it's important in countries like Japan, China, East Asia, Chile. So if you're going to prevent gastric cancer, we must prevent transmission in very young children. Okay, and what we know is you get it before the age of 5. Our theory is you get it around that toddler age group. But our problem was we didn't have a test that was good enough for young children to do. they wouldn't swallow, you know, I don't know if any of you've ever had a urea breath test, but it involves swallowing a little liquid. And they learned to have many of that nonsense for research purposes or otherwise. So it was older when they could, you know, swallow the little bit of medicine that we need them to take for a lollipop afterwards. They'd swallow it quite happily. But at a young age, they didn't swallow it and we got false positive tests. But what we should, but it's important to know what age. So how are you going to prevent it? There's no point then looking at children who are 7 or 8, there's nothing to do. They'll have it if they're going to have it, and they won't get it again. And it's because they pick it, children, toddlers, put everything in their mouth, cereals in their mouth, bottles, and that's how it's transmitted within families. Mother puts the bottle in her mouth, gives it to the baby, transmission infection. This is why it's really important, you know, the dividing and classifying and understanding what you have is really important. And it's simple classification a lot of the time, okay? So the other important thing around counting everybody is no duplicates, okay? And because of the current system of medical counting in this country, we can't, you know, hospital numbers, patient is referred from Cavan to Beaumont, they have 2 hospital numbers, they're counted in Cavan, they're counted in Beaumont. And for years, the CF registry had huge issues around double counting and the number of patients with CF in the country. So it's taken us a long time to get a proper census every year, okay? The other thing you can look at is where are people cared for? Are they cared in appropriate settings? Are they at home? Are they in the most suitable place? Or are they in places that are totally unsuitable? What are the current care practices? Does everybody get the same level of care? One of the major changes in the care of cystic fibrosis is that whether you're born in Donegal or Drimnagh, your care plan is the same. There's only one difference, huge difference in where your CF centre is. There are now only 11 CF centres in Ireland designated for care of patients. So if you happen to be living in Donegal, the most likely care centre is in Dublin, but you will get the same care as if you live in that. And that's really important. That is equity of care, really important. So therefore, it's important, is everybody getting the same care, the same treatment? What are the issues around improvements in care? What would make a difference? What are the trends in disease outcome? Like I've shown you in CF registry, we have shown the huge improvement in life expectancy in CF in Ireland and internationally. Are we making effective use of the limited resources? I don't have anybody else going to say this, but there's a lot of resources in CF currently and wasted. Like, and I think everybody must be realistic, but for the numbers we have, you know, the new medications now are hugely expensive. End-of-life care for older adults as they live longer will be expensive. But there's an awful lot of expensive care going into pediatric hospitals where the numbers just aren't there. And we have to be, you know, on what you have, you hold, like if you have 3 consultants and 6 nurses, you don't have the numbers. I think we have to be realistic about this, and I think it's, you know, it's difficult for me. I work and I'm dependent on the CF care teams. But, you know, if somebody's looking for a budget, where is the money in the budget? What else could we do? We have invested hugely in CF, but we don't need to continue the same level of investment. We might have money for elsewhere. We might spread the budget, you know, the budget a little further, okay? And the important thing, I think, is that data from a registry allows you to plan services, plan what's needed, understand what's needed. Okay? The other really important impact of registries is patient-important outcomes. What's important to the patient? And this is something that, you know, I tried to think about today in terms of what would be important. And one of the issues I find in CF, because I'm not involved in care, is there's unrealistic expectations of the, you know, the providers of what the patient can do, what the patient wants to do. Who wants to do physio every day? You know, what benefit is it? Who wants to take, you know, patients with CF who have to take tablets 3 times a day, unless they have an acute infection, they don't take them. We did a lot of work around what patients actually take, because we were interested in, you know, medication causing liver disease. What was very clear, if it was once a day they took it, There's a little tablet that is totally ineffective for liver disease, but anybody with any evidence of liver disease got it and they took it. And yet any medication that was prescribed 3 or 4 times a day, they didn't take. Like a lot of the time, we're making their lives worse. So, the patient-reported outcomes are really important. I don't understand what it might be for acute brain injury, but that's for, patients and their families to determine. And realistic ones that are really important. I think don't be high in the sky, about it.
And how do you explain that they just stop to take medicine? They feel better at the moment and they decide to stop along.
It couldn't be happened. Would you take tablets? Like even for most of us, if we have antibiotics 3 times a day, how often do we forget? Right?
If you have, regular timetable schedule to look after every 6 hours to get a good show.
Yeah. No, so it is just we don't do it. And so therefore we need better ways, better treatments. Does it make any difference if you take them twice a day, morning and evening? Probably not if you take them all. But it's important to understand what are the important outcomes for the patient, okay? On quality of life metrics, and the important issue around quality of life is to use validated questionnaires. And the other issues, as mentioned, is cost of care and how effective are different interventions. How much money do we waste on stuff that is of no benefit? But we do it because it's all we can do. So what would be the priority for SAOL now? What would make the most difference and the most impact? And I think these are only questions you can think about all the time. What could you do that's easy, relatively straightforward? And what's for the short term and the long term? Where would you begin? Well, I think, as I said previously, you would assess national and international what's out there, what kind of databases are there, who's done what, and more importantly, who's trying to do what and failed. That those are really important lessons. Because somebody who's failed will tell you what they did wrong. Okay, so that's really important to know. Okay, I think you need a lot of stakeholder consultation to establish the priority questions. But I think being focused, I think you've got to be very, establishing whose priorities. Lots of people have different priorities that don't make any difference to those who are most impacted by the disease. So like deciding what the priorities are. And then I think you need a small representative group of stakeholders who are passionate about the idea of having a registry, because I think it will be based on passion. It needs funding, lots of other stuff, but it most importantly needs passion, because I think it's something that can be quite, I think it was more difficult, but I think it is actually getting easier now because there's an acceptance that registries contribute hugely to patient care, okay? And this small group needs experts in acute acquired brain injury. You need patient representatives or families, technology experts, because that is really important. You need, and then I think you need data collection experts, data management people, who will find the right question, the right data you collect to answer the question you want, okay? You have to be compliant with GDPR, but I think the important thing around GDPR compliance is that it's just something you get on into. We've resisted it. Everybody has their right to privacy. It's awkward, it adds to it. But in the end of the day, it is about asking permission. And it's about telling people what you're going to do. And the real test of it is one simple question. Would patient X be surprised if they knew this is what happened or what you did with that? And that's what's really important. Do they understand? Have you got proper consent? Have you explained it? And consent, sadly, is a largely verbal process. Writing out long information leaflets is not of benefit unless you actually get explain to the parent or to the patient what you're doing, what you're going to do. And you can explain it to a 3-year-old without any difficulty. You can tell them what you're trying to do in the language they understand. And the important issue is to remember everybody has the right to say yes, and everybody has the right to say no. But in my experience, the most important thing to manage is not getting it straight out. Because it's not always a good time to ask. Like people might be really, my favorite story about you know, consent and CF is, I asked a woman one day for consent, you know, about participating in the registry, and she just said, look, you know, just go away from me, leave me alone, you know, right? And about 9 months later, I was in the, you know, in the clinic in a big open area, and I was there, you know, she saw me and she came in and she made a beeline, but she was coming to see me. And I was never the most popular person in that place, but anyway, she came in, she was see me. She had 3 kids now with CF, and number 4 was born, and number 4 was all right. And the day I asked her, I didn't realize that she was pregnant. So it was very, I would never have asked her, I knew. So she sat down and sensed what was I doing, what information they need, everything. And this nurse came in and said, Dr. Kenny, we'll see you now, Mrs. And she says, well, I'm not finished yet. You know, so it's, she, you know, but this is the whole idea of, you know, if I'd pushed and said, will you? And she'd say, no, I haven't time, I can't do it. She would have, you know, it was just about waiting for the right time for people who are really stressed. Like, we think our lives are stressful. People like this are so stressed, we don't, you know, it's hard to ask, find the right time to ask, but it's about giving information and slowly, but getting permission, taking them as part. I call the people who work in my study participants rather than anything else, because they're not my patients, they're co-participants. Our control group are really important. So it's important to remember that, okay? So what else? Okay, and also you've got to get ethical approval, and who that will be for is really interesting in terms of Beaumont, Cork, National Rehabilitation Centre. But there is word of a national ethics committee for registries. The independence of the registry is paramount. It needs to be a company limited by guarantee and with a charity number, and needs to be independent of all patient organisations. So also independent of oneself. It can be vested, supported, all the rest of it, but it has to have an independence. And also independent from the caregiver is really important, because they don't want the poor outcomes report. They only want good news stories, and that we all want that, okay? I have some more on good data collection, but I think we'll leave that. I think there's, you know, but it's important, I think, to collect the right data to answer the question. Don't collect what's meant for, collect the important data. That's where I would leave you. And wish you the best of luck in your efforts to establish a database.
Thank you very much.
I realize everybody see the side of my face now.
Somebody has a question. Could they just mute themselves and this in the chat? I don't know. So, yeah. Maybe I ask something because you know, Marx before when my brothers talked about all those reports that the government has. You know, I've read some of them, and I think other people would draw here and I've read them too. The one thing that is really strange is that they come up with strategies and plans, but they haven't got, you know, they haven't got an idea about the numbers, you know, where those people are, how many of them there are, and what is it they need, when they need it, and there is no, you know, apart from that, on top of that, there is no budget allocated for implementing plans. There's no person made responsible for implementing plans, and there's no timeline. So I don't know. I mean, they're all eminent experts. They're large groups of experts who put all that stuff together. But I wonder, you know, if or whether, I mean, they're smart people, so they should really know that there's no chance at all to make what they have proposed happen anytime soon, if all those things are lacking. So it would not be, you know, the right thing to start with the registry like that, so that you know what kind of problem you do.
This is the same for all conditions, but you need to know the size of the problem, whether it's diabetes, heart disease, cancer, and it's only, I think it's only pressure where, you know, the Department of Health will come to establish registries. They're not going to do that donkey work. Establishing a registry is very hard work. Collecting the data is hard work.
So that's what I think that will say.
The case for the CF registry. The CF registry has a grant allocation from the HSE under an SLA or something like that. So they've got a small amount of money. And largely drug companies have funded the work of the CF registry. And now more recently, the really interesting thing that's happened is that clinical trials on drugs were done with, you know, new drug comes to development, and there are clinical trials to see if the drug work, is safe, are there side effects. So that's your clinical trials. But now the European Medicines Agency, there was always an issue of, okay, so you have the clinical trials and the drug is 90% effective and everything is fine. But then, you know, GPs start prescribing and they didn't find the same efficacy level, it wasn't as good, there were side effects that weren't reported. So now the European Medicines Agency has decided that there must be post-authorization data. So once they've approved the drug for use in the population, that they must have data afterwards to see how effective the drug is, what the long-term side effects are. Because most clinical trials only go for a couple of years. And they've decided that they will use registry data for a given condition to look at how well the drug behaves and post-authorization. And for the cystic fibrosis registry, new modulator drugs, which are based on, you know, gene modifications, they have become available in Ireland. So they, you know, the European Medicines Agency wants to know how well do these drugs work, how long do they work for, and the CF registry provides this data funded by the drug companies. They get a non-restricted grant from the drug companies for, you know, for 5 years. Or for, you know what I mean, for a length of time, miserable with what the European Medicines Agency requires. So this will fund the registry for that length of time. So at the moment, we have a lot of funding. But I have been at meetings where we didn't know what we were going to do about staff budgets for the next year, unless we got money. The drug companies have, on the whole, in CF, funded the registry very well. But it's a hugely intensive drug, you know what I mean, drug requirement in CF. Is it independent and totally is independent of the drug companies as I'd like? I'm not quite sure this is, you know. But it's, you know, it's the only way that you're going to get substantial funding.
Yeah, so
there has to be some sort an interest, somebody who need funding, because registries are a data intensive activity. So they're a staff intensive activity. Our biggest cost, our only cost really in CF registry is staff. Very, you know, in the lines of it's based in UCD, so rent and all of that is very many costs. You know, the staffing costs are huge. They run about 78% of the total costs of the registry.
I think that's the problem with you know, we're not in as well. We discussed that before, but nobody was thinking of the wildest to stop treatment or turning the real consultation.
Yeah.
You know, saying, you know, he's going to buy anyway, so why is that not good like this? Whereas in the context of brain, that's a common argument. So, you know, that's most likely not to make any option. So we won't raise any money on that.
Yeah.
And I think, I don't know, but I think part of that reasoning is based on interests by pharmaceutical companies who conserve drugs and cancer patients, but not somebody who is therapy.
And that, yes, that is the sad fact of it all.
Yeah.
Like the Vertex is the drug company that has invented all the new modular treatments for cystic fibrosis. And they are funded by the North American Cystic Fibrosis Foundation, which is the North American patient organization now, a very, very wealthy organization in relation to CF associations around the world, that they have funded Vertex, and they have made Vertex a huge company. And so it's fine, you know, and Vertex now dishes around to other, you know, companies. But it is sadly a fact of life, but you have to work with the pharmaceutical companies, or otherwise you have no money. Now, for acquired brain injury, I wonder if the HSE might consider funding you at a very small amount to do, you know, just to get the numbers, just to do a census. Like, I mean, you can't start with, you know, bells and whistles for a registry. And I think this is where, like, even just knowing, like, and the HSE does provide various registries with funding. The exact details and all of that, I don't know, but I do know it provides registries with funding, and registries are seen by the HSE now as an important part of service delivery and service planning. And they feed into all the, you know, the clinical care programs, you know, on the size of the problem and the outcome, and they measure the outcomes. Registries are really useful for measuring outcomes. If you have outcomes for, you know, if you have a, you know, a clinical care program for diabetes, and your metrics are retinopathy, foot ulcers, diabetic control, but then a registry is a perfect way of measuring the outcome for the new care pathways in diabetes. So I think that shift has happened, you know, in general, that registries are something that are particularly useful. And if you could, you know, have your funding a little bit separately for an organization that would provide the evidence and the data. And I was just talking earlier to Bill and Simon when I came in about how would you know where. But I think for acquired brain injury, I think we have like a record of how many happen in a given year, 2, 5 years, whatever. You know, they can only start out in, you know, 3 places in Turkey. And they do now have your ICD code, which will be used for the high registry. So I think there is some way of collecting that data. And like, I think it's the GDPR piece, the ethics and consent, and the strategy, you know, the question, what do you want to know? Do you want to, would it be enough to know how many people there are?
Small.
Yeah, but I think, but you can't, I don't think you can start, like if there was a, you know, if there was a registry in the UK that was established and big, you could piggyback to that or otherwise. But if there are no registries elsewhere, you can only start small.
Well, what I say is that they stop it. 10,000.
So they want to build and register for the next years, and now there's a lot of coming from the state to build that and to build up the kind of they can combine all the numbers. Everybody's not the east, the west, and all the south, so should do it, and then yeah, you have to put all of them together.
And do you have a unique patient identifier? Does every patient have their own?
Everyone has got it, and I see, you know, I see number, I see how there has to have everybody.
Yeah. Yeah, okay, so it's just that. And that's it. Yeah, it makes it, because then you get duplicates, like for years, the cystic fibrosis registry, in doing this, like one of the important things, if you're doing it, you need to know what coverage of the population you have. So then you can infer from the data you have. And if you don't have good coverage, it's a waste of time. But you have to know what the denominator is.
Some groups, for example, some, stroke, they count, what injuries?
Maybe it counts.
But there's no point where it gets together. There's no.
You see, the interesting thing as well is that, the change in the care of stroke over the last 10 years has been immense. Like there is now no, to see a patient now. I have 2 children that are geriatrics, and one of them is in England in stroke care, doing stroke care. And like to see somebody now with a disability following stroke is a measure of how ineffective you work. You know what I mean? It's a measure of poor care. Now, there might be reasons for it. They might have got to hospital at the time, all of the rest of it. But you don't expect to see patients who are treated in hospital within the appropriate time having a disability now from stroke, which is a huge change from 10 years ago. And you wonder whether, with acute brain injuries, there won't be, I know some of them are, and I keep saying acute instead of acquired, sorry, that there won't be a change. You know what I mean? There is an injury there, so it's hard to know. But I think that our understanding of what's going on, I think, will improve.
And then it's all starting to be something that not to be the role. But you have to be the role for information. Know where people are, how many of them are, where. One very important aspect of what we said was that, when something new starts, often money is going to throw it, because you don't know how much you do. We don't talk about that in relation to the global beginning. There were lots of therapists there, lots of support. It's not too different from here, we don't have huge amounts, but even when we started, we didn't really know how much was off to do this. And then over time, we started measuring, we started looking at how many clients or patients have we got, and how much resources do they require, how many people do they need to support them, and then you start measuring, you start to streamline it. You have a duty to do that, because you're really having the normal rates. And that's sometimes we go really well. The money is cut to the point where the really is service. So having the swings on, it is important to be about it.
And do you okay, so it would be lovely to have a national database and all the rest of it. Do you have a database here or a registry here of the work you do? That, even if you were to take, the patients that you see here, to begin to say, well, let's just establish a registry with what we have. Let's just look at what we have, what we're doing, what our outcomes are. Let's get, and let's, independence is critical in this, and independent, if you say this is what we did and we collect our own data and we produce our own data, it has less value than if you say, well, okay, so we gave this job to, an independent person, maybe, a voluntary agency or something, to collect data according to, specific criteria. That wouldn't be very different from what you probably collect clinically now, but it's just using the data in a different way, and might be an interesting start, even to get the idea of getting some kind of a database together.
It's a framework, it's like a focus group.
Yeah.
You try it out and see, well, how well does that work for
yeah.
you?
Like, who do we have